Well, thank you, everyone.
Thank you.
Good afternoon. This is Dr. Joelle Vlahakis. This is the draft local coverage determination, or LCD, open meeting conducted by WPS. Today is October 25th, 2023, and it is 1 o'clock. This is Dr. Joelle Vlahakis. I am one of the contractor medical directors with WPS, and I'll be facilitating the meeting as well as moderating. Today, we really want to be able to take comments from our stakeholders on the draft LCDs we have listed. But before we start, it's always nice to know who's on the call. I'm going to ask my colleagues at WPS to introduce themselves, and we'll start with the CMDs who are on the call.
Well, good afternoon, everyone. My name is Denise Nachotsky. I'm one of the CMDs at WPS, and I welcome all of you who will be attending today. And thank you for your time and efforts.
Hi, this is Dr. Jill Sumfest. I'm also a CMD at WPS. And again, as Dr. Nachotsky said, thank you very much for attending today and being willing to comment on the proposed LCDs.
This is Dr. Juan Shenin. I'm one of the medical directors for WPS, and I am grateful for your presentations and your interest in commenting in our proposed LCDs.
Okay, will the policy coordinators please introduce themselves?
Hi, my name is Emily Zahner. I'm one of the RN policy coordinators with WPS.
Hi, I'm Michelle McCurry, and I am a policy coordinator with WPS.
And will some of our other colleagues from WPS please also introduce themselves?
Good afternoon, everyone. This is Linda Oliver. I'm the Director of Medical Clinical Management here at WPS.
Hi, this is Richard Staley. I'm the Policy Administrative Assistant for WPS, and I am helping Dr. Vlahakis by running the technical portion of the meeting.
And Morgan, were you able to get your microphone to work?
I sent her a request unmute, but it looks like she's unable to do so. She may have to call in on the phone line.
So it looks like Morgan's having some more technical difficulties. Linda, would you like to introduce Morgan on her behalf?
Sure would. Morgan Covarrubias is our clinical supervisor over our policy coordinators.
Wonderful. Thanks so much, Linda. All right. So what I'd like to do is just take a few minutes to review our procedural procedures, and then we'll go ahead and start taking comments on the draft LCDs. So we need to make sure we let everyone know that we're conducting this meeting in accordance with CMS IOM Publication 100-08, Chapter 13, Section 13244. So our purpose today is to take public comment on draft LCDs, and that's the only thing we're going to do today. This meeting's open to the public and it's being recorded and will be transcribed. Both the recording and the transcription will be available in a few weeks and posted on our website. All callers are currently muted, but what we're going to do is we'll introduce each of the draft LCDs up for comment and invite comments. There's two types, so there'll be the formal comments, and those are formal presentations. Those have been submitted in advance. And then after that, we'll take any public comments. Please let us know when you wish to comment by clicking on the raised hand icon, or if you're on the phone, use *3. When Mr. Staley calls on you, please make sure, if you can, that your microphone's working on your end, not on mute, and that your speakers are also silenced. And I'd like, of course, to remind everyone, if you're not speaking, to kindly make sure you remain on mute. And then when you comment, if you can let us know who you are, of course, your affiliations, and let us know if you have any conflicts of interest and the nature of that conflict. Be as specific as possible in your comments so that you can better help us improve that draft LCD. If a previous speaker has made a point with which you agree and you feel you want to go on record as agreeing, by all means, let us know that you agree with the previous speaker, but there's no reason to necessarily read anything anyone else has stated. We're going to give each speaker 10 minutes, each of our LCDs equal time. Mr. Staley will provide a 2-minute warning, which is helpful. He lets us know to keep on track. And then I will ask the speaker to stop simply at the 10-minute point. If we have a slide presentation, and we do have several, Mr. Staley will advance those slides for our speakers to avoid any technical difficulty, because as you can see, sometimes those occur. So really, this is one of the most important things that we do at WPS. We really want to listen to your comments. We don't respond necessarily to those comments during the meeting. We want this to be an opportunity for you to give voice to your expertise, concerns, etc. When you have any comments or questions specifically requiring a written response, we ask that you send those to Medicare Policy Comments at WPSIC.com. I'll have Rich put that in our chat box so you have that at the ready. Please include the topic of the LCD on the email subject line. That helps us stay organized. And of course, if you have supporting literature, attach that either in a PDF or Word document to that email. Unfortunately, because of the nature of our system, we can't follow email links specifically. And then all responses are for educational purposes only, and it's important to note, do not establish Medicare or WPS policy. Comments will not be addressed individually, but will be compiled and addressed in a response to comments document posted with our final LCD. Rich, do we need to pause for any other technical difficulties?
I am not certain. Let me just check, because I see that Dr. Pansare is also calling in on her phone, so I just want to make sure that I can hear her. I'm going to promote her to panelist quick.
Hello, can you hear me?
Yes, Dr. Pansare. Okay.
Yes, wonderful. All right.
Thank you.
So I'll just start by explaining that the open comment period for these LCDs is from September 28th until November 11th. So the ones that we'll be talking about today are listed in the agenda. Let's go ahead and start with our first, because it sounds like we have our technical difficulties ironed out, at least for the time being. So the first draft LCD is DL36805. It's entitled Lab Histochemical Stains and Immunochemical Stains. This policy identifies medically necessary criteria for the use of special stains and or IHC stains. Its policy also, based on claims review, was able to highlight scenarios that may be driving medically unnecessary or overutilization or incorrect billing services. So this draft LCD aims to correct some of those. It is the responsibility of MD Dr. Jill Sumfest, and it will remain open for comment until November 11th. So we have two formal presentations for this draft LCD, and it sounds like our first presenter is going to be Dr. Vaishali Pansare. Apologies if I pronounced your name at all incorrectly.
And Dr. Pansare, I have requested you to unmute again. You can go ahead with your presentation.
Thank you. So my name is Vaishali Pansare. I'm a pathologist at Corewell Health East, which was formerly Beaumont Health in Southeast Michigan. I will be talking about immunohistochemical stain, LCD, specifically related to the prostate course. Next slide, please. And I have no financial relationships to disclose. Next slide, please. So before I go into the actual LCD statements, I just wanted to bring your attention to the National Comprehensive Cancer Network, or NCCN, risk categories that are utilized for prostate cancer, and most urologists use the NCCN categories for treatment of these patients. So based on the NCCN risk categories, these patients are divided into 5 risk categories. It's a risk classification system based on multiple clinical pathology characteristics. I want to draw your attention to some of them. So the 5 groups are very low risk, intermediate risk, high risk, and very high risk. So if you can look at the yellow highlighted areas, for very low risk, the patient has Gleason score of less than or equal to 6, which is a 3+3 grading, less than 3 biopsy cores are positive, and less than 50% of the cancer in each core. In the intermediate risk category, the tumor is slightly higher. It's Gleason score 7 or 6, and less than 50% cores are involved. It becomes a favorable intermediate risk category for this patient. If they have more than or equal to 50% of cores involved and a grade group of 3, they become an unfavorable intermediate risk category. A high risk includes a higher Gleason score, 8 to 10, and very high risk. I want to highlight the area that I said tumor volume and biopsy is very important to risk stratify this patient. Next slide, please. And why this is important is because this risk stratification actually determines the prognosis and treatment therapies for these patients. So a very low risk category patient would get active surveillance, whereas a low risk category patient may get brachytherapy or another local treatment. And a high risk patient could get a radical treatment like a radical prostatectomy and lymph node dissection. So this does have a significant impact for these patients. Next slide, please. The first LCD statement that I want to bring your attention to is the statement that says that it is not reasonable and necessary to bill for IHC testing or immunohistochemical testing in a negative or suspicious core biopsy when obvious prostate cancer is present in other cores. I want to highlight 3 examples for you. The first one is when a patient has a Gleason 3+3 equal to 6 cancer in 2 of the cores that were submitted. Typically, they'll give us 12 or 13 cores, 6 from each side and 1 targeted core. This patient now becomes a very low risk group and may get active surveillance. Whereas if it's 3 plus 3 equal to 6 cancer in 3 cores, then this patient falls in the low risk group and may not get active surveillance alone. If a patient has a 3 plus 4 equal to 7 cancer in 6 of the 13 cores, it falls in the favorable intermediate risk group category, whereas if there is one more additional core, a 7th core that has the same Gleason score 7, then the patient becomes an unfavorable intermediate risk group category. Next slide, please. So another example along the same lines is about the laterality. If a patient has a 3 plus 3 equal to 6 cancer in 3 cores on the right side of the prostate, the patient is in low risk group category. However, in addition to these 3 cores, if there is an additional core on the left side that the patient has the same Gleason score of 6, 3 plus 3, then the patient falls in the favorable intermediate risk group category. Next slide, please. The second LCD statement I want to draw your attention to is where it says that the prostate cases where IHC workup is not reasonable and necessary include these 2 bullet points. The first one is a multi-part biopsy with 3 plus 4 equal to 7 cancer in one part and atypical small SNR proliferation suspicious for 3 plus 3 equal to 6 cancer in other parts. So this is a very small focus, small tiny glands and a small focus that the pathologist is suspicious but cannot confirm it without an immunostain whether this is cancer or not. And the LCD statement says that stains are unlikely to change treatment. Let's look at this example. The patient has a Gleason score 3 plus 4 equal to 7 cancer in 6 cores. Patient is in favorable intermediate risk group category. In addition to that, now if I did a stain on a 7th core where I'm suspicious or it is an atypical small SNR proliferation suspicious focus and it proves to be cancer, now the patient moves to the unfavorable intermediate risk group category. Next slide, please. The second bullet in that same LCD statement states that it's not reasonable and necessary to perform immunostains in a multi-part biopsy when you have 4 plus 3 equal to 7 cancer in one part and atypical cribriform glands in another part. When we have atypical cribriform glands, the differential diagnosis is an intraductal carcinoma of the prostate or an invasive Gleason pattern 4 cancer. And the LCD statement says that it may not change treatment, whether it's intraductal carcinoma or an invasive Gleason 4. However, as I've highlighted in this example here, if the patient has 4 plus 3 equal to 7 cancer in one core and has intraductal carcinoma in another core, patient is in favorable intermediate risk group category. However, if I did an immunostain on this and it turns out to be an invasive Gleason 4, now this becomes a 4 plus 4 equal to 8 Gleason score in that additional core. Now the patient is in a high risk group category and may get significant treatment. Next slide, please. So as you can see that immunostains to confirm malignancy in these foci actually would have a major impact on patient management, and knowing how many cores are positive, what grade they are, and what percentage of each core is involved is critically important for the pathologists and for our patients. In summary, I would like to ask WPS to allow coverage of these very important immunostains by removing those 3 statements. The first one that refers to immunohistochemical stains in a negative or suspicious core when there is an obvious prostate cancer under the core. The second statement was about multi-part biopsy with 3 plus 4 equal to 7 cancer and atypical glands suspicious in another part. And the last one was about the 4 plus 3 equal to 7 cancer and atypical cribriform glands. Thank you.
Thank you so much for the time that you clearly spent putting this together. I wonder if anyone has any questions for the doctor. Okay, hearing none, I just want to thank you so much for presenting for us this afternoon. We have another presenter, Dr. Matthew Waskow, who's asked for a little bit of time this morning. Rich, can we get his presentation queued up? Oh, beautiful. Again, thank you so much, Dr. Waskow, for offering to speak to us this afternoon.
Yep, happy to be here. My name is Matthew Wasco. I am a pathologist, a general pathologist at Trinity Health Hospitals in Southeast Michigan. My primary area is genitourinary pathology, but I also do many other things. You can go to my next slide. And I also have no financial relationships to disclose. Next slide. So my comments are focused on this statement, which was in the LCD coverage guideline, specifically the second part, where it says it is rare to need stains to prove that an endometrial or ovarian cancer is a serious cancer, or that a kidney neoplasm is an oncocytoma, an eosinophilic or chromophobic renal cell carcinoma. Next slide, please. Basically, I want to discuss oncocytic renal tumors briefly. CT-guided biopsies have become increasingly important in the last 20 years. As recently as about 15 years ago, we only saw a handful of renal mass core biopsies in a single year. But a couple of years ago, it was up to 62 per year. Core biopsies are becoming increasingly important as many patients have these identified small renal masses, and surgery to take it out and diagnosis is not always an ideal option. And many of these patients, they want to either watch or ablate them or do local therapy, or to perform some kind of testing or diagnosis before surgery to guide it appropriately. And so therefore, accurate diagnosis on biopsy is crucial. And of course, accurate diagnosis on resection is also crucial. Next slide. And so basically, I wanted to call your attention to the newest WHO classification of tumor kidneys. There are many, many new and emergent entities, and you're free to investigate all these and read about all of them if you like, but suffice it to say that the number of renal neoplasms has expanded significantly in the last 20 years. Next slide. Specifically from an article on emerging neoplastic entities, this comment from an article stated that these entities or groups of entities are increasingly characterized by specific molecular features, often associated with either recognizable, specific morphologies or constellations of morphologies and corresponding immunohistochemical profiles. And thus the correct diagnosis has clinical implications. So essentially what this statement is indicating is that there are many things, including immunohistochemical stains, that are important in evaluation. Next slide, please. And so for renal tumor diagnosis, an additional article from 4 years ago states there are no morphologic features, just the H&E stains, et cetera, that are diagnostic of certain histologic type of tumor, and one growth pattern or cytologic features that can be seen in a variety of tumor types. So morphology is not always king in kidney tumors. IHC staining is particularly useful and perhaps indispensable in many situations in resolving these questions. Next slide, please. In particular for oncocytic renal tumors, there are emerging variants as well as recategorization and expansion of previous categories. In the past, it was mainly oncocytoma, chromophobe renal cell carcinoma, but there are also some newer versions, some of which have higher clinical aggressiveness, and some of which are low grade, can be watched. So correct classification becomes important. WHO also states that you cannot make definitive diagnosis of oncocytoma on core biopsy because the intratumoral heterogeneity of chromophobe renal cell carcinoma can be very similar to oncocytoma. But because these biopsies are done a lot, careful evaluation allows many pathologists to favor one end or the other on this spectrum, and oftentimes immunostains are useful in that. Next slide. And so the question is, what do experts do in this question? And so this study below refers to a survey of academic genitourinary pathologists and how often they used immunohistochemistry in the evaluation of oncocytomas or potential oncocytomas. There were only 6% who said rarely or never, and there were 24% who said in all cases, but the majority fell in the spectrum of they use it a lot of the time or only when there's a specific question they have answered. So the statement in the LCD that it's rarely or never important would only apply to even 6% of experts. Next slide. And so there are the most commonly stains used in this differential are listed here and available in table form there. There are, you know, new stains every year for kidney, and some of them have become more common as we go on. But the ones at the left end of that table are the ones that have been used for years and are increasingly used. And as we go forward, there will probably be other stains that become more important as they are found to be important. So there are other stains where only if specific morphologies are identified are they useful. Next slide. So there are other uses for renal stains include carbonic anhydrase 9. Many renal neoplasms show some morphologic overlap, as we said before, and undifferentiated tumors can be impossible to classify with just morphology. And in those cases, immunostains are often useful. And CK7 and a CA9 combination is useful in distinguishing clear cell carcinoma, which is a malignant tumor which can be very aggressive, from clear cell papillary neoplasm, which is thought at current to be a low risk tumor and has not been demonstrated to have metastatic potential. Next slide. So conclusions are that immunohistochemistry and occasionally other techniques such as molecular testing or genetic testing are of paramount importance in accurate classification of renal neoplasms on core biopsy and on resection. And this is important for treatment and therapeutic options. And as I noted, there are many new and emerging entities. And so our ask for this specific statement would be that that statement be removed, as it's not, I guess, real life to say that immunostains are rarely necessary in this differential. Next slide. There was also one additional statement that I wanted to comment on, which stated at the second half of that statement said that combinations of P53, Ki67, CD20, and CD44 on bladder biopsies from select pathology practices. There's an error in this, and that CD20 is not the stain that is meant to be used here. That would be cytokeratin 20, CK20. And I wanted to note that a combination of P53, Ki67, cytokeratin 20, and CD44 are sometimes used in difficult cases to evaluate for urothelial carcinoma in situ. Many of these are small biopsies, difficult to evaluate just on morphology. It's not routine. But as these stains are variable, a combination of two or more is often used. In our lab, we usually use 2, sometimes 3, but it's limited to select cases where it's thought to be helpful. Usually morphology is diagnostic. And that's all I have there. So my request for this would be, it's fine to note that combinations of those stains are used, but certainly should not be CD20. It should be CK20.
Thanks so much, Dr. Roscoe. We have a couple of requests. One is that if you could kindly send to us the articles that you nicely outlined for us as references, that would be extremely helpful and beneficial for us. And then I understand we have a question from one of our attendees, Dr. Gupta. I understand you are one of our esteemed J5 CAC members. Please go ahead.
Thank you. Can you hear me?
Yes, perfect.
Thank you for the opportunity. I actually was, so my name is Chaksha Gupta. I'm a pathologist and chief medical officer here in the state of Missouri, in Liberty, Missouri. I wanted to go on record in support of the presentations by Dr. Pansari and Dr. Vasco. I would like to also state that, as pathologists, we need to have accurate and complete diagnosis for our patients. and to ensure the best management for our patients. That's the primary goal for all of us. And we need to be able to work up cases using the most appropriate immunohistochemistry stains that we feel is best for each case. In addition, we spend time in analyzing them, and we assume risk for the accuracy of our reports. So we feel that we should be adequately reimbursed for our work and not left wondering if we should be using immunostains to guide patient management. The other point I'd like to add is Dr. Vasco about the immunohistochemical cocktail stains or multiplex immunostains. We are seeing smaller and smaller biopsy material nowadays. There's a stage shift from large excisions to small image-guided biopsies, and we have to conserve tissue not just for diagnosis and for additional stains as needed, but also molecular studies that guide patient management. So thank you.
Thank you. Any other comments or questions for our presenters?
Dr. Vlahakis, this is Rich. We do have another statement from Dr. Pansare. And Dr. Pansare, just if you have any statements in the future, just use the raise hand icon and I will open your line for you. But she says that it is extremely important to classify these renal tumors appropriately as they behave very differently. I just signed out a renal tumor with implication for entire family due to genetic inheritance, only diagnosed from initial biopsy immunostaining.
Thank you, Dr. Pansare.
And we also have a statement from Dr. Jeff Craver. Dr. Craver, I have sent a request on mute and I saw it go green and then it went mute again.
Yeah, I just
there you go.
Myself. Can you hear me?
Yes.
Okay, I'll start over again. I'm not sure how much you heard. I'm Dr. Jeff Craver. I'm a pathologist, medical director at SSM St. Mary's Hospital in Richmond Heights, Missouri. And I'm also an officer and director for the Missouri Society of Pathologists. I want to speak in agreement with Dr. Pansare and Dr. Wasco. I enjoyed listening to their excellent presentations. And also, I really enjoyed Dr. Gupta's comments. They're to the point and very accurate. I agree, we strive in pathology to preserve as much tissue as possible and not waste them doing immunohistochemical stains. When we do immunohistochemical stains, they're for a specific purpose, try and make an accurate diagnosis and get the patient started on the most correct course of treatment as possible and minimize the need for further biopsies. And get the patient set on the appropriate course for treatment. I also want to call attention to the fact that I do support the letter written regarding the LCD from the CAP. It's dated July 17th, 2023. You should have that available. I think it's an excellent letter and points to a number of other areas with different CAP requests. I understand some of them have been addressed already, but I think that's an excellent letter. Thank you very much.
Hi, it's Denise Nachatsky here from WPS. And I would just like, I'm sure that Joelle has stated, but if I can echo enough here that as CMDs and as we write policies here, we look at an invaluable, a large amount of medical literature, but it is the experts such as you who are out there in the community and the front line taking care of our beneficiaries that provide such invaluable information and insight. And we really, truly appreciate the time, the research that you provided for us, because we are all here to help our beneficiaries. So thank you so much for everyone who has presented and provided comments.
And we're going to get a copy of that letter that you mentioned, Dr. Craver, so we can make sure we have that to take a look at as well. I think the comments that we've gotten are very cogent, and we certainly appreciate the level of expertise and subject matter experience that you have out in the field. Thank you. Okay, just in the interest of time, I'd like us to go to our second draft LCD, and that is specifically DL 38686, and it's entitled Implantable Continuous Glucose Monitoring. This LCD modifies the coverage criteria for implantable continuous glucose monitors based on best available evidence. As many of you can imagine, staying current with what's available is one of our greatest challenges as CMDs. And when we have Class 3 medical devices that require pre-market approval by the FDA, we also, in addition, have to make sure that they're also reasonable and necessary. And as we have indications for use, we want to make sure that we stay on top of those as well. We want to make sure that we're offering the best evidence available so that our blood glucose measurements really enhance our diabetic treatment decisions. We have a volunteer presenter, Dr. Kaufman, ready to go. So I'm going to allow you to present. This policy is actually, or the LCD is responsible of our own Dr. Juan Schoening, and it's open for comment until November 11th. Thank you, Dr. Kaufman. Please go ahead.
Thank you very much. Can you hear me?
Yes, we can.
Oh, good. Thank you. So I appreciate this opportunity. My name is Dr. Francine Kaufman. I'm the Chief Medical Officer at Senseonics Incorporated. I'm also a Distinguished Professor Emerita at the University of Southern California, past President of the American Diabetes Association, a member of the National Academy of Medicine, and I continue to see patients in my clinic. Next slide, please. So I do have a conflict of interest to announce. I'm the Chief Medical Officer at Senseonics, the maker of the only approved fully implantable CGM, continuous glucose monitoring system. Next slide. I just briefly want to introduce you to the system. There's actually 3 components. One is a very small 3 by 13 millimeter sensor that's fully implanted in the upper arm, over which lies a smart transmitter that enables the charging of the powering of the sensor, then takes back the raw signal, calculates the glucose value, and sends it to a mobile app on the patient's cell phone. The glucose value is refreshed every 5 minutes. There's trend arrows, there's alerts elicited as well on the mobile app as well as on the transmitter itself. As opposed to the other CGM products, which are transcutaneous and inserted by the patient themselves, as well as removed, that lasts 7, 10, or 14 days, our fully implantable system lasts 180 days, lies in the subcutaneous space, and measures interstitial glucose value. So it's inserted and removed by trained and certified healthcare providers. It is a replacement for finger stick blood glucose values, and we're indicated only in adults at this point in time. Next slide. So we are very pleased with the draft LCD that discussed the removal of the requirement that the beneficiary be insulin treated with 3 or more daily administrations of insulin or use a continuous subcutaneous insulin infusion system or an insulin pump. In addition, we are very pleased with the addition of the beneficiary being allowed to have an implantable sensor if they have a history of problematic hypoglycemia, regardless of what therapy they may be on. So the updated criteria for coverage for the implanted CGM better reflects the current clinical evidence and standards for the reasonable and necessary use of continuous glucose monitoring in patients with diabetes. And there's a robust body of evidence in the medical literature supporting this position. There are a number of randomized controlled trials showing the benefits of using CGM in type 2 diabetes patients who use basal insulin only, rather than those who only take multiple administrations of insulin. There are 3 systematic reviews with meta-analyses that showed CGM use in patients with type 2 diabetes compared to finger stick glucose management was associated with a significant reduction in hemoglobin A1C values, the measure of glycemic control for people with diabetes. And there have been 2 prospective clinical trials showing that hypoglycemia can be missed in patients with type 2 diabetes without using a continuous glucose monitor. The major professional diabetes associations in the United States have made favorable recommendations for the use of CGM, and in particular in patients with type 2 diabetes on basal insulin only. Next slide, please. So Senseonics supports the draft LCD DL38686. The changes in coverage are in concert with the medical literature and positions of the major diabetes associations. The updated coverage criteria provides parity for coverage for implanted CGM compared to those in the DME space or the transcutaneous continuous glucose monitoring systems that are self-inserted by the patients themselves and of much shorter duration. However, we do respectfully request that WPS add all relevant ICD-10 diagnoses to the DA 58213 so that both DME, CGM LCDs, and the WPS Part B for the implantable CGM have parity on the ICD-10 diagnoses. Next slide. So we do request, and we mentioned this in our official comment that has been submitted, that we have provided a list of 81 ICD-10 diagnoses codes currently not included in the DA 58213, but are included in the DME CGM LCD. And this does create confusion for the providers who are looking for consistency across the covered diagnoses. And it's really essential that the following more commonly used ICD-10 diagnoses be added. And this is one that discusses diabetes mellitus due to underlying condition with unspecified complications, type 1 diabetes with unspecified complications, type 2 diabetes with unspecified complications, and specified diabetes mellitus with unspecified complications. Next slide. So in summary, Senseonics appreciates WPS' timely review of the implantable CGM LCD to bring coverage criteria parity across all CGM systems. We support the updated coverage criteria included in the proposed LCD. And however, we do request that the draft coding article DA 58213 include the requested ICD-10 codes to ensure parity across CGM systems. And thank you very much.
So This is Dr. Shannon from WPS. I want to thank you for your thoughtful presentation and the support of Sensonics for our coverage criteria. Your comments regarding the billing and coding article will be brought to the attention of our national work group to be discussed and addressed during the comment period. I just want to make note that the DME LCD addresses home glucose monitors and continuous glucose monitors. And due to the more limited scope of our LCD to implantable continuous glucose monitors, there may be inherent differences in the coding regarding those LCDs. And finally, regarding the coding itself, I always like to make note that is according to coding convention, we advocate for providers to use the most specific codes available when using ICD-10 codes. But your feedback is extremely valuable, will be taken to the national work group to really address this during our comment period. And I just wanted to thank you and just give you some insights, but this will be discussed by the work group. So this is not our official position. Our positions are written in our common response document.
Thank you very much.
Rich, do we have any other comments or hands up?
I see no comments at this time. If anyone in the public would like to make a comment on this draft LCD, please press *3 if you're on a phone or use the raise hand icon and I will open your call. There are no raised hand icons at this point.
Okay, thank you, Dr. Kaufman, for your presentation, and thank you, Dr. Sheening, for your very cogent comments. Let's head to our third draft LCD, DL 39716, which is entitled Cataract Extraction. This describes coverage for cataract extraction and intraocular lens implants, which are based on services which are reasonable and medically necessary for the treatment of our many, many beneficiaries with cataracts. This policy further defines coverage and describes criteria necessary to justify the performance of cataract extractions. It's the responsibility of policy coordinator, Michelle McCary, and our contractor medical director, Dr. Jill Sumfest, and it will remain open until November 11th. We do have a formal presentation for this draft LCD, and I'd like to introduce Dr. Maria Woodward, who has kindly offered to share her expertise. Dr. Woodward?
Thank you so very much for the invitation to speak here today. My name is Mia Woodward. I am at the University of Michigan and a cataract surgeon. I operated actually this very morning on did some cataract surgeries. I'm speaking on behalf of the American Academy of Ophthalmology and ASCRS, who represent nearly all of the cataract surgeons in the United States. We have a very comprehensive and cohesive group of ophthalmologists who belong to these two organizations. Next slide, please. Or am I able to advance? May I have the next slide, please? Thank you. I have no financial disclosures. So I wanted to start with some definitions. Cataracts are a degradation in the optical quality of the crystalline lens, which goes from clear to, as you can see, very opaque, that can affect not only vision, but also visual function, which can come in many different forms. Most cataract development is related to aging, and it can occur in one or in both eyes. And you'll see me often referring to our very recent preferred practice pattern, which is a peer-reviewed publication through the American Academy of Ophthalmology, where a large panel of experts in this domain meet and discuss best practices, and then come with a cohesive document. Next slide, please. So in that American Academy of Ophthalmology's preferred practice pattern guideline, the current indications for cataract surgery are when there's a decline of visual function that impairs daily activities. The way I say this to my patients is, do you have problems doing what you need to do or want to do for your function in this world? And vision and visual acuity means that it no longer meets their visual needs or their visual function. And additionally, we also evaluate if removing the cataract would be a reasonable way to improve their vision and their function, and it has a reasonable likelihood of success. And there are several other indications for cataract removal, which are also covered in the LCD. Next slide, please. Our concern in the LCD is the mention of a specific visual acuity target of 2050. There's a significant number of cataract patients with vision better than 2050 who really struggle with their activities of daily living. And what we found is that there's really no single test that can adequately describe the effect of a cataract on a patient's visual status or their functional abilities. When a person is in the eye clinic, their distance vision is tested using a high contrast chart in a low light setting. And this really can underestimate their functional problems in the real world, like when you're driving at night in the snow that is coming here in Michigan soon enough. And honestly, what I most commonly hear, and most of us hear, is people complain of glare, halos, and starbursts around light. So they really stop driving, and starting with stopping night driving. Or they can't read and they have trouble seeing things on the screen, like on a TV screen. And so they have reduced reading speed, or they have trouble reading, so they stop doing that. And that has to do with contrast. So there's many different ways that visual acuity can affect people, not just their acuity, although of course acuity is part of the equation. So should the proposed LCD be implemented, really this would be the only MAC that with a visual acuity cut point for cataract surgery. And we have concerns that this would deny medically necessary care to beneficiaries. There have been visual acuity cut points in the past. And back when it might have been appropriate in the 1980s and 1990s, when it took people 10 to 12 weeks to recover from cataract surgery before they could see well. And there were more complications during surgery. So there had to be a rationale for it being worth having to do the cataract surgery. But over time, those were all eliminated from the various protocols because they really didn't add visual acuity in that setting of a dark room, high contrast chart in an eye lane and an eye clinic really didn't capture that visual loss and visual functional problems. So we're just concerned that adding an actual number to this LCD would be a step back in really focusing on the health and well-being of our patients to regain visual function, especially given how well people recover from surgery and how much they have to gain in terms of their visual function. Next slide, please. So, as I had said, there are many things that can make it difficult for patients to perform the basic activities of daily living when they have cataracts. They have trouble eating, getting dressed, doing buttons, seeing detailed things, doing shopping, being in bright settings with those lights that are in big stores, doing personal finances, writing checks with that gray on black paper or blue on black paper that has poor contrast, managing their medications with medication bottles and how small, and again, poor paper to look at those bottles, and driving, as this picture shows. So again, visual function is not always reflected in the measurement of visual acuity. Next slide, please. So in summary, we really do believe pre-op distance visual acuity alone is an unreliable predictor of postoperative functional improvement. And so the decision to perform cataract surgery should not be solely based on Snellen visual acuity. And I do want to clarify that in the proposed LCD, the WPS does acknowledge that a specific Snellen visual acuity cannot support or deny medical necessity. If you look under the visual acuity section, that's clear in the document that is there's not the only measure of poor function. So we urge you to ensure that Medicare beneficiaries with cataracts have meaningful access to the cataract surgery by providing coverage for this medically necessary cataracts procedures. And we hope this would be accomplished by eliminating that visual acuity cutoff that's proposed in the document. Next slide. I believe that's my last slide. Yeah, okay. And thank you. I'm happy to answer any questions, and I really do appreciate the time that you've given me to speak on the behalf of our organizations.
Thank you so much, Dr. Woodward. This was really, really helpful, very cogent, and I'm just so impressed. All of our presenters are going under time today, which is great because we have quite a bit to go through. I'd like to give folks an opportunity, though, to ask questions or give continued thoughtful comment.
Once again, if you have a comment to make, please use the raise hand icon or press *3 if you are calling in from a touch-tone phone. There are no comments on this draft at this time.
Thanks, Rich. I'd like to reiterate some of the comments my fellow CMDs have made, which is to say that we really do appreciate the level of expertise and professionalism you all bring to illuminate our efforts on trying to make these LCDs make medical sense, be thoughtful, and be appropriate. So thank you again so much to all of our presenters thus far, but thank you, Dr. Woodward. That was excellent. If no one objects, then I'll move on to our next LCD, again, just in sensitivity to how many we do need to go through today. So our next one is DL 34648, which is entitled Bisphosphonate Drug Therapy. This is a reconsideration of coverage and expands the indications for IV bisphosphonate treatment. They're all listed in a very useful chart, but it is a reflection of some of the excellent research being done on behalf of many of our patients that might benefit from or suffer from bone loss and have that be ameliorated. It is the responsibility of our policy coordinator, Emily Zahner, and our CMD, Dr. Denise Nachatsky. It will be open for comment until November 11th of this year, but I'd like to open it for comment now.
Again, the raised hand icon or *3 on your touch-tone phone if you would like to make a comment. There are currently no comments for this draft LCD.
All right, thank you, Rich. Okay, so we'll go on to our next LCD DL 38680, which is one of our MolDX LCDs, molecular testing for solid organ allograft rejection. This LCD is complex.
Dr. Villekas, I think we lost you.
Yeah, what a surprise. Once in a while, technology does not cooperate.
Dr. Vlahakis, are you still there?
I think that was an operator error. So Dr. Nachotsky, I'll open it up for comments at this point, and I'm going to try to work on my technical stuff here.
Okay, Dr. Vlahakis, let me help you out here while you have your technical difficulties resumed. But this MolDX 38680 for molecular testing for solid organ allograft rejection, it is actually provides limited coverage for molecular diagnostic tests used in the evaluation and the management of patients who have undergone solid organ transplantations. These tests can inform decision-making along with the standard clinical assessments used in their evaluation of organ injury for active rejection. I just want you to know that with this draft, this LCD is actually coming back to draft, and the whole purpose why this one is coming back to draft, it is just for revision for clarity of the coverage criteria section and the CAC session, which was held on November 16th and 17th in 2022. There is no change in the coverage from that policy. We only took the comments from subject matter experts from those 2 days in November 16th and 17th in 2022. It was a multi-jurisdictional CAC meeting with subject matter experts, and during that time we took some of the literature from them and their advice, and this is why it is coming back for a draft. But again, there was no change in coverage, just clarity of coverage. We do know from those 2 meetings, those CAC meetings, in November 16th and 17th, that the CAC, during that time, we had this multi-jurisdictional CAC to discuss molecular testing for the diagnosis of acute rejection in kidney, liver, heart transplant with gene expression profiling and donor-derived cell-free DNA. They were discussed. The subject matter experts expressed a high degree of certainty that there is sufficient evidence to support the use of molecular tests that I have just stated. However, the subject matter experts also agreed that there's a lack of data to support the routine use of molecular combination testing. Moreover, they did not endorse the use of molecular diagnostic test in lieu of biopsy in patients who have a very high clinical and laboratory suspicion for acute rejection, who could safely undergo a biopsy. So this is just a revision for clarity of coverage criteria. Any questions?
If you would like to make a comment on this draft, please press the raise hand icon or *3 on your cell phone. There are no comments on this draft at this time.
Okay, well, I'm going to try again. Let's move on to our next LCD. It is DL 39709. It's entitled MolDX Gene Expression Profile Tests for Decision-Making in Castration-Resistant and Metastatic Prostate Cancer. This is also the responsibility of Dr. Denise Nachotsky and will remain open for comment until November 11th. This particular LCD describes our coverage policy for gene expression profiles when we're assessing the risk and trying to predict therapeutic response in men who have an established diagnosis of castration-resistant or metastatic prostate cancer. This particular LCD illuminates some of our coverage indications, limitations, and the medical necessity. Testing is considered reasonable, necessary to guide treatment decisions in men with prostate cancer, especially when measuring life and managing prognoses. We also need it for determining response or likely response to drugs and biologics. Are there any comments or questions at this time?
I see no raised hand icons or star threes at this time. There are no comments.
Excellent, Rich. Thank you. All right. Well, we are moving through. Congratulations, everyone, and I appreciate your patience as we try to make sure we have the opportunity for comments on these LCDs for our beneficiaries. All right, so our next one also within the confines of the molecular, L39711, molecular biomarkers for risk stratification of indeterminate pulmonary nodules following bronchoscopy. This is also the result of hard work of our Dr. Denise Nichotsky, and it will remain open for comment through November 11th. It's also likely that our draft is in fact a reflection of increased knowledge and understanding of pulmonary nodules, and it is, as you can imagine, very exciting, but also very important that we try to keep up as best we can as a Medicare advisory contractor, which isn't always easy to do. So this allows us to further target patients who may be at risk for lung cancer, especially if they have an indeterminate pulmonary nodule following a non-diagnostic bronchoscopy. And that has to be when all conditions are met. And as many of you are probably aware, diagnostic bronchoscopy can be quite an exercise, and it can often require the highest skill level of our interventionalists and pulmonologists. So this specifies that we'll have limited coverage for molecular tests to aid in the diagnosis or exclusion of lung cancer with a patient with an indeterminate pulmonary nodule, especially following a non-diagnostic bronchoscopy. These are the conditions that have to be in play in order for this coverage to take effect. The beneficiary has undergone a bronchoscopy for that intermediate pathology, and we've failed to provide a specific histopathologic diagnosis. And test results would be used to meaningfully inform our patient management within the framework of nationally recognized consensus guidelines. If medically reasonable and necessary, following those established guidelines, and the nodule cannot be evaluated by an alternate methodology, things such as an EBUS or an FNA, and the beneficiary doesn't have any of the other of the following, meaning that these would be exclusionary: a personal history of cancer, a current diagnosis of cancer or high clinical suspicion, an overall low risk for pulmonary malignancy, such that the test again would not meaningfully alter the patient management or significantly improve patient outcomes, that this be an overall high risk for pulmonary malignancy, such that the test results would likewise not be meaningful, or would it improve patient outcome, that the beneficiary has not been tested with the same or similar assay for the same clinical indication, that the beneficiary is within the population and has an indication for the test, which was has the indication for which the test was developed and is covered, that the test has demonstrated clinical validity and utility, establishing a clear and significant biologic or molecular basis for stratifying those patients and subsequently selecting either positively or negatively a clinical management decision. We need to have clinical validity of any analytes or expression profiles measured, which must be established through a study published in peer-reviewed literature for the intended use of the test in this intended population. We want to have tests which have a high sensitivity and a negative predictive value, such that patients can be safely selected for a less aggressive management strategy without delay to diagnosis due to false negatives. And parenthetically, we want rule-in tests which have a high specificity and positive predictive value, such that patients can be safely selected for more aggressive management without significantly increasing procedures without cancer. So we want it to be a good test that benefits our beneficiaries in short summary. Rich, I'd be happy to take comment and questions.
Thank you. Once again, use the raised hand icon or press *3 on your touch-tone phone. There are no comments on this draft at this time.
Okay, very good. And then we'll proceed on to draft DL 39713, our trigger point injections, which is a restatement of when trigger point injections will be a covered benefit. It specifies under what circumstances and frequency of treatment, for example. It is been the responsibility of our policy coordinator, Michelle McCary, and written by Dr. Robert Kettler. We have a comment period remaining open until November 11th. Comments now?
There are no comments for this draft at this time.
Thank you. I think we might actually be at our last LCD. When we first started, I wasn't sure we were going to get through all of it, but you guys are really wonderful. And we've had an exceptional array of presentations this afternoon as well. So without further ado, we'll work on our last draft LCD, DL 39720, molecular testing for risk stratification of thyroid nodules. This has been the responsibility of policy coordinator Emily Zahner and Dr. Denise Nachatsky. We have a very important diagnostic test coverage for folks with thyroid nodules. It is a very, I'll say, involved and long LCD. I'll try to summarize as succinctly as I can. It is really written so that we cover these molecular diagnostic tests with intermediate or suspicious thyroid nodules in patients that meet certain categories, and they use the Bethesda categorization to help stratify those patients. Our proposed draft includes coverage for these molecular diagnostic tests, which outline when it would be medically reasonable and necessary to apply these tests, which include things such as technical assessment, need for clinical validity and utility in peer-reviewed published literature, including the opportunity to stratify patients and select appropriate patients. And I know we've had such wonderful input from some of our pathologists and the like. If there are subject matter experts available that would like to make a comment, we welcome it now. And of course, open comment for public.
Thank you one more time. Raised hand icon or *3 on your touch-tone phone. There are no comments on this draft LCD.
Sorry about that. Once in a while, my microphone button just doesn't like to work. So I'd like to reiterate how grateful our WPS team is for those of you who took the time to present, to give us thoughtful comments, to help elevate and illuminate our writing such that we deliver what we want, the best care for our Medicare beneficiaries that is possible. If, again, you have any comments that you'd like to submit to us in writing, please do so. We have the email address there, policycomments@wpsic.com. Please don't hesitate. We do read those. We seek them out, and we appreciate the time that you take to gift us those, and I do mean gift us those. We only know as much as all of us working together, and as we were communicating prior to the meeting, no one can know everything about everything, and what you do really helps us do that. Rich, if you'd like to do any housekeeping now, that would be fine.
Thank you very much. I see we have no more comments out there. If anyone just before the meeting is adjourned has any other comments they want to make on any of the drafts, now is the time to press the raised hand icon or *3 on your touch-tone phone.
Okay, well, I am just going to, again, express my appreciation for your attention, for us staying on time, and to just continue to submit your comments to us. We do take them under consideration. Have a wonderful rest of your day, and thank you again so much.